the recording and we'll start going over it. Okay, the hypersensitive clients, what to do, idiopathic hypersensitivity, risks and considerations. Can neurofeedback cause an adverse response? That's a term that's being used quite a bit today rather than side effect, because side effect is supposed to be related to a drug. But in fact, side effect is really a better term than adverse response, because the FDA looks at adverse responses as relating to drugs. And we may get into that. Any intervention can cause an adverse response. Relaxation can cause an adverse response. Undocumented triggers can cause an adverse response. MSG in your food, a reaction to a new drug, a bad interaction with somebody of significance in your life, something that's coming up that day and you don't realize how much of a problem it's causing you in terms of stress. The placebo effect can cause an adverse response, right? You can give somebody a placebo pill and tell them it's going to make them feel worse, and they will feel worse. Complex variable interaction can cause an adverse response. So the interaction between two things that normally you don't do or take could cause an adverse response. An adverse response is not legally the same as harm. Remember, it's not the same as harm. We're going to go over that. We're going to look at the FDA's own rulings on that. So what is idiopathic hypersensitivity? And what are the attributes and characteristics we're looking for? These people who have idiopathic hypersensitivity have very significant anxiety scores usually. So you're looking on your maps for beta asymmetries, a high overarousal. They're often subject to panic attacks. They frequently have a history of it. So when you do your history, you know, always ask about panic attacks. They typically have a lot of problems sleeping. They don't get to sleep, they can't stay asleep, and one of the reasons they're probably so hypersensitive is because of the sleep deprivation. We know that we need to sleep now to clear out the debris from excessive anxiety, and we can't do that in the brain if we aren't getting sleep. They're usually hypersensitive to barometric changes. That's a real indicator. You know, I always ask people if they seem extremely anxious and have a history of a lot of problems, who've been to a lot of doctors. I always say, are you really sensitive to changes in the weather? And what kind of sensitivities do you have? Will the weather actually make you feel so bad that you can't get out of bed, or you don't want to leave the house, or you get extremely depressed, or have a lot of strain symptoms? It's important to ask. They're often hypersensitive to EMS, F, okay? So they'll often report that when they're around electromagnetic activity, they begin to feel worse. It could be a computer, it can be a toaster, it could be a microwave, some things more than others. And of course we know microwaves give off a lot more EMF than your toaster does. They usually have a very high physiological score. So if you're using the NewMind system, you're going to see them up there at 200, 240. Some of them on occasion, if they're professionals, like medical professionals, they'll underreport their physical symptoms. So note their profession. I've seen that pretty consistently. A lot of the professional people underreport their physiology problems. But usually these people have very exaggerated symptomology. It's across the board, and they have very high physiology scores both. They typically have a history of problems with healthcare professionals. They have one failure after another, and there's usually a fair amount of anger, frustration, fear, and resentment involved. And they don't feel that they're heard, and they feel they're minimized, and they're usually in a state of contention with most of the professionals. And there may be good reason for that. I'm not saying there isn't. I'm just saying that's another sign. They usually have a history of constantly changing diagnoses. In other words, every person they go to see gives them a different diagnosis. And it may not be that exaggerated, but I'm exaggerating just for example's sake. So you're going to see quite often, one person said they had Lyme, another said they had dysautonomia, another said they had Bartonella, another said that they had bipolar disorder, and the list goes on. And they have all kinds of medications they've been through. They usually have a very traumatic emotional history, and they often have a lot of features of axis 2, particularly narcissistic and borderline. They may not be fully there, but they're pretty close. A lot of times you can feel it, if not capture it in a PAI. So look for that. The qEEG will often elicit symptoms. So if they just come into your room and you put a cap on them and start running a qEEG, they'll report symptoms during the qEEG or post-qEEG. They'll call up later, well, that really threw my whole system off doing that qEEG. So if you get as far as a qEEG with them and you get that report from them, that's a major red flag. Beware, you're dealing with this issue. The last person who made that report to North Carolina claimed that when they sat down in front of the EEG amplifier, the hairs on the back of their neck went up, their heartbeat started to get dysregular, and they began to feel very peculiar. Okay, that's not typically the type of behavior you see in your average neurofeedback client, and even in your sensitive client. These are hypersensitive clients. So if you have any suspicion at all, ask the person when they sit down to do the training with the equipment, or if you're going to do a map, how do you feel? Do you feel okay? Very important. What kind of qEEG patterns do we typically see in these hypersensitive clients? Usually there's elevated beta or elevated relative power beta, or you'll see when you shift up that there's beta on our map system. They usually have a strong frontal beta asymmetry, and that tends to put them kind of in the category of panic disorder. Engels et al. Noted that people with panic disorder tended to have more strong right frontal beta asymmetry. So in your map, you may see only a partial beta asymmetry. It may not be full, but it will be right frontal, typically. And it may even be strong enough to show up in the magnitude. Alpha for these people is typically fast in most cases. And that tends to correlate with a serious blood sugar dysregulations and adrenal problems. We've run the stats on that. I haven't published it yet, but I will probably next month if I get time. But that's a pattern you often see. And they frequently have delta deficits, not always, but look for that as well. Now, I looked at a couple of the maps of the hypersensitive people I've worked with, and that's what they look like. When I identify them, I do work with them. So I have many cases, but it takes a certain level of patience and expertise to do it, and we're going to try to bring you up to speed on how to do it if you really want to try. Okay, what do you do if you get a qEEG and you get as far as training them? I often won't even do a Q with them. What I'll usually do if I have this kind of client and I suspect that they're hypersensitive, I will take them during our greeting session. We do meet and greets, but you could just set up a session too with them if you wanted to. And I'll have them come in and I'll do neurofeedback for 1 to 3 minutes, and I'm watching them like a hawk when I do it. And every step of the way, I'm asking them, how do you feel now? How do you feel now? Okay. And what am I doing with them? I'm doing CZ SMR up only, at like 75, 80%. So it's barely an effect. Okay. So we're doing an easy to reach percentage of the reinforcement, 75, 80%, SMR up only, in the thalamic cortical loops over the motor strip, because it tends to be a calming protocol that shuts down excess sensory input, which is what these people need a lot of the time. So I will ask them once they sit down, how are you feeling? I'll hook them up with the sensors. And then I'll ask them again, how are you feeling? Do those sensors feel okay? If I start to get reports of symptoms, that's it. We don't go farther. We're done. And I tell them, you are too unstable for neurofeedback. And that's what I'll do. Then I'll start, if they aren't having any problems, then I'll start running a protocol. And every 30 seconds, I'll ask them, how are you doing? What are you feeling? Are you feeling any different? If I get any reports of symptomology, I stop immediately. Don't push it. And then I tell them, you're too sensitive for neurofeedback. If they can get through 3 minutes of neurofeedback, okay, I'll stop there. I don't charge them. You don't want to incur any liabilities of any kind with these people. I don't charge them at all. And I send them home. And I ask them to call me later that night. And if they don't, I call them. Are you having it? How do you feel? I call the next day. Want to know, how are you feeling? You stay on top of this because you're showing due diligence. And they feel more supported and more heard when you do it. Now, another thing you can do at the same time is monitor their HRV. What you'll find with all of these people universally is they have the worst heart rate variability you've ever seen, and they cannot do heart rate variability training to save their life. You can put them on that thing, you can work with their breathing, with their imagery, you can just go to town for a whole hour, and you'll get just about nothing out of them. So that's another sign. It doesn't hurt to hook up both at the same time and monitor them, because if they start to feel any unusual physiological changes, it'll show up. The heart rate variability will look worse. You'll see that the screen looks worse. Their heart rate will speed up, so you'll see the line moving up to 90 beats a minute or higher. You'll see it get more erratic, and they may not report, or they may be delayed in the report. So careful scrutiny of the client response at every step of the way is critical. Okay, we want to watch for rapidly shifting delta. One of the features of these people that's very common is that they have a very dysregulated brainstem and limbic system. Those two do not communicate well, particularly with the hypothalamic pituitary axis and the brainstem. And those frequencies, based on the research, communicate primarily in the delta range. And what's typical with these people, you'll see often, is that they will have large shifts of delta at the same time their symptomology is coming on. It could be a massive drop in delta, I'm talking 5 to 10 microvolts, or a massive elevation, and they won't be moving an inch in their chair. No toe tap, they'll just be dead still, and their delta will be peaking and dropping, and they'll be having strong symptoms. This is another sign of dysregulation at that very basic level of functioning. You'll also see their heart rate changing rapidly during these elevations as well. That may make you ask, well, maybe I should do infraslow with these people. I've tried that. It doesn't touch them. It's a nice idea, seemed to make sense, but sometimes it makes them even react more powerfully. So you want to be very careful what you're doing. SMR is about the safest. And as I said, don't charge for the initial service. Okay, when do the adverse reactions occur? Typically post-session, right after the session. By the time they get in the car, they get home. Usually it's when they get home. They're going like, I felt terrible. I had to lie down. I had the shakes. I got a headache. I started sweating. I couldn't get to sleep that night. I was up most of the night. Next day, I felt even worse. Common, 60 to 120 seconds of SMR, and this is how they respond. How long will it last? It can last up to a week. I've followed these people. I've had many of them over the last 20 years, and I'll follow them. Usually, the moderate cases dissipate in 36 hours. The symptoms finally go away. The really, really strong cases, it can take a whole week. All right. The person who filed the reports claimed it just kept going on and on and on. Okay, that's highly unlikely as a consequence of the neurofeedback, and we'll see why. And of course, it may involve a large range of symptoms. And here are the symptoms that typically you see reported in these hypersensitive clients. They often report that they're very fatigued, they don't have any energy, they're really anxious and panicky, they may be weeping. They'll often report visual disturbances. Headaches is one of the most common one. Dissociation, it's probably from thoracic breathing and strong shifts in tidal CO2, which is easy to see in the heart rate variability. So when you do that too much, you start to experience dissociative derealization, that kind of thing. Loss of concentration and focus, obviously they can't focus. Irritability, they're hypersensitive to light and sound to begin with usually, so that's another question you can always ask them. Are you sensitive to barometric pressure? Are you really sensitive to light and or sound? That really gets there. They'll have to block out all the light in their house and sit quietly. They often have dizziness and lightheadedness. That's really common as a response and of increased negative mood. Okay, an even more conservative approach than trying the neurofeedback if you want to try to help them. I may get somebody like this and I know right off the bat, I can't do anything with them other than biofeedback. So I'll hook them up with the HRV, monitor the response, and then I'll start working with them on their breathing. They'll usually have difficulty learning to breathe, and they'll often hide the fact that they aren't doing what you're asking them to do, and they'll try their own different things. They tend to be fairly non-compliant and passive-aggressive in that sense. They often have a very short frustration level. They'll try just a little bit for a few seconds and they'll give up. They may not tell you, and then they'll try something else without telling you, and you have to constantly monitor them and get confirmation that they're doing what you're asking them to do. And even then, they often won't do it, and they get very frustrated. Which is, if they can't stay with it, they can't. If you can get them to do HRV, then have them practice at home until they're really good at it. You want them to be able to beat level 1, on the HRV, get up to like 80 or 90 on their green score, and have nice smooth waves. They don't have to be big, just nice smooth ones. Then they might be candidates for some initial SMR training, and then go back, do it for a minute. See if there's a response, and then try them 3 minutes. And watch for the coherence loss patterns, of course, when they're doing HRV. They often have very frequent, they'll start to get it and they'll drop it. They'll start to get it and they'll drop it. Start to get it and they'll drop it. They're often dissociating, worrying, ruminating, mild panic. So our neurofeedback approach, what are we going to do with it if we're going to really pursue neurofeedback? We're going to perform a qEEG, as I said, with all of the monitoring and questioning. We're going to train single channel over the motor strip. We're going to do the protocol based on the map. Initially, you're just going to do SMR up, but if they have too much delta or theta or alpha, once they demonstrate that they can, do a 5-minute session with just SMR, then you might consider adding an inhibit, a very modest one, maybe a 30% inhibit on a BrainMaster, 70% on BioExplorer. And so you do those 5-minute sessions, they come in, and I often don't even charge them for those first sessions, or I charge them, half price or something, just, because they ate up room time. Again, you want to show them that you're on their side, that you hear them, that you support them, and because of their access to tendencies, it's better not to charge them initially until you develop a really good relationship with them. Build up to 10 to 15 minutes. If you can get them to do HRV level 1, get them up to 15 minutes, then they probably have a shot at getting a good outcome in managing this. If you don't, you're probably not going to get anywhere with them, and you need to send them to somebody like James or Adam if they want to deal with them. They probably have severe methylation issues that have not been identified, something along those lines. And they really just need long-term careful physical care until they can get strong enough to come back and get to a level where they can do neurofeedback. While you're doing these kinds of sessions with them, watch for patterns of fatigue. When you're training them, if the delta suddenly goes up, or they start getting too much alpha, stop the session. Don't push it. These people are unusual. And do not ever use photic with these people. With photic, will completely mess them up, to use a technical term. Possible sources of adverse responses. Okay, so what's causing the adverse response? Oh, it's the neurofeedback that did it, I was fine until I did that neurofeedback, except you look at their history and they've just been a wreck the whole time, So in that case, there's a lot of things that, if they're that sensitive, all they have to do is walk by, your PC on the way out, and it might dysregulate them. But the first thing you have to do is rule out magical theories. Neurofeedback is not magic. It doesn't do magical, unseen things. People often approach it that way. And you really need to take that myth, that mystery out of it. It's just operant conditioning learning theory until we know for sure it's different. We need to keep people thinking about it as just learning, okay? We're teaching allostatic balance, but these people have very fragile allostatic balance. That's why they're often termed dysautonomia. But, a lot of these people may have Lyme's. In fact, many of them do, undiagnosed Lyme's, and they're an advanced case. And you'll see the delta in the brain map because they've got white matter, hyperintensities, lots of little strong inflammatory areas. And that's what's going on. It could be Bartonella, other things. Placebo effect can certainly cause it. People sit down in front of a strange new device and they often have adverse responses. It's very common. It's recognized. Hypochondriasis, some of these people really just overinflate all their symptomology. And they're going to overinflate anything they feel while training. In a sense, it's part of the placebo effect. A paradoxical response to relaxation. That is a very real thing, and a lot of people don't understand that unless they're trained psychologically and they've used relaxation techniques. Relaxation techniques can elicit adverse responses or side effects, especially if the person's been traumatized emotionally in any ways, and that brings us to PTSD. PTSD often drives a lot of these people or really aggravates their existing symptomology. If you've got advanced Lyme with PTSD underneath, you're going to have a really hypersensitive client. So look for that. So here's a profile of somebody who came in fairly recently that I'm working with dysautonomia. I even have somebody who flies in from out of town who's a neurologist who thought it was the neurofeedback that did it to him. And it took a lot of work to get him to realize that it wasn't necessarily the neurofeedback that was doing it. It was the change in his nervous system as he calmed down, that whenever he relaxed, it could do it. So here's a profile. You can see this map is nothing really too outrageous here. Right? That's why it's very physiological. It's very brainstem based. You do note there's a real deficit of alpha. I've seen that often in these people. and a deficit of beta in this person. There's many different profiles because there's many things that can cause this extreme dysregulation. In this particular case, we had a lot of a lot of fast alpha, indicated blood sugar dysregulation. But the map is not really, it's not really that remarkable, right? Let's look at the connectivity. Okay, we look at the connectivity and we start to see stuff, right? We're seeing that beta hypercoherence, and that's a typical sign. I'm not getting my spotlight from here, okay? That's right here. That's a typical sign of excessive sensitivity to perceptual input. So these people may have sensory integration problems. In 70% of the cases that we see this, when we ask people, they say, yes, we do. And a lot of the ones later begin to realize they've had it so long that they've managed it so long they don't pay attention to it anymore. But we've got quite a bit of hypercoherence here, you notice, and it's across the board. And you do see that in kids with autism often. You'll see that one of the most outstanding things a lot of times in their maps is some beta with excessive hypercoherence across the board. Not, we've got a fair amount of intrahemispheric too. Then here's R, beta asymmetry. Very strong, usually in most of these people, a strong beta asymmetry. That's their anxiety. That's that ramped up right hemisphere, overactive amygdala, excessive norepinephrine, excessive cortisol. Here's the metabolic profile. Look at that score. 276. Look at all of the problems here. And we knew the adrenals and blood sugar would be out. Look at this score. This person's on thyroid medication, which is why their map didn't show slowed alpha. But probably one of those cases, because hypo's at 32 and hyper's at 23, where they're flipping back and forth. A lot of medical people I've talked to say a lot of people with thyroid problems, they shift back and forth between fast and slow. It's probably part of what's going on with their dysregulation. Here's the rest of their list. I mean, it's a pretty impressive list. For a map that's so kind of unremarkable in many ways, this is a very remarkable physiology. This is dysautonomia. And no clear medical problem, thyroid, that's it. But this person is profoundly dysregulated. They had all the symptomology that I presented earlier. They usually have a lot of anxiety and depression. You can see this person is carrying around a significant amount of that. But we're not seeing elevated competitive down here. We're not seeing elevated perfectionistic. So the map is not that indicative of psychological issues. And the ISI is not that indicative of psychological issues. And yet they've got a lot of symptoms of anxiety and depression and a huge amount of symptoms, particularly metabolic ones. So we know this is a metabolically based issue. It's very difficult to train against them. I mean, this person's interactive. They like people. They're not that avoidant. They're cooperative, flexible, assertive. This person's also young and extremely intelligent. And it's the last way she wanted her life to turn out. So that kind of covers a profile and how I manage it. And I want to address, as a consequence, this concept of do no harm. We have to ask, when these effects occur, are they placebo or side effects? Are they side effects of relaxation? Side effects of meditation? Or similar to that? And we should consider what's an adverse effect versus a side effect, and what's the definition of harm. The definition of harm in all the medical literature going back almost 100 years to the 1930s and earlier is unexpected noxious effect, and that term is never defined legally beyond that point. An unexpected noxious effect. That is the medical term of harm. So you might think as a psychologist, oh, well, I'm feeling really bad, or I got a headache today, or, God, I got a headache, I got nausea, I'm dizzy, I'm feeling terrified, I had a panic attack. That's not an unexpected noxious effect by the FDA standards. You might be able to argue to some degree medically, but it gets really complicated really quick when you do that. Really, how the FDA looks at all of this is risk-benefit ratio. So, in the red, I'm putting you, here's Section 513A of the Federal Food, Drug, and Cosmetic Act. Okay? A balanced consideration of probable benefits and probable risks is an essential part of the FDA's determination that there are reasonable assurances of safety and effectiveness. So they look at these devices and they look at the risks and benefits, and they have algorithms, calculations they make, very specific ones, to assess risk benefit. And EEG equipment has not produced quote unquote harm on the record in decades. It's been out there. Okay. They accept for evaluation well-documented case histories conducted by qualified experts, a lot of that in our field, reports of significant human experience and testing on clinically derived specimens, DNA, tissue, organ, and cadaver studies. Okay, we have over 280 studies in our field done by experts that show a fair amount of efficacy, that much replication by most scientific standards indicates that there's a probable pretty good benefit here, particularly when you consider that the risks, according to the FDA, are very low with this class of equipment. What is a serious adverse event? Okay, device-related serious adverse events. This is a device. This is what you're using, a device, class 2. Those events that may have been or were attributed to the use of the device and produce an injury or illness that is life-threatening. Notice that word, life-threatening. Results in permanent impairment or damage to the body, or requires medical or surgical intervention to prevent permanent harm to the body. How often have you seen that coming out of somebody doing neurofeedback? As far as we know on the record, that has never occurred in decades. And most of the people, even these really hypersensitive people, do not experience that level of harm. That's what we mean by harm legally with the FDA. So I wanted you to have that in mind so you have a sense of boundaries and what's what here. Okay, the FDA would factor whether an event occurs once or repeatedly into the measure of probability. They're also concerned about duration of harmful events. How long were the adverse consequences? Some devices can cause temporary minor harm. Some devices can cause repeated but reversible harm. And other devices can cause permanent debilitating injury. The FDA would consider the severity of the harm along with its duration. We just don't. We're not in this class of events here. And if you do wreck somebody's sleep, by the way, usually you just switch your symmetry and their sleep comes back. So we can reverse. I mean, we're not even in the ballpark here. The FDA also honors uncertainty. There is never 100% certainty when determining reasonable assurance of safety and effectiveness of a device. However, the degree of certainty of the benefits and risks of a device is a factor we consider when making benefit-risk determinations. Okay, they already know there's uncertainty. And they look at, well, how much uncertainty and how much risk and what's the benefit? It's sometimes difficult to distinguish between a real effect and a placebo effect. They recognize that in the absence of a trial design that is capable of blinding investigators and subjects. Well, okay, we know that they're aware that what's going on is a placebo effect. How about risk tolerance? Here's another consideration they look at. When making a benefit-risk determination at the time of approval, FDA recognizes that patient tolerance for risk and patient-centric assessment of risk may reveal reasonable patients who are willing to tolerate a very high level of risk to achieve a probable benefit, especially if that benefit results in an improvement in quality of life. Well, we're talking about stuff like chemotherapy, radiation therapy, things along this line. This is serious risk, and people are willing to take much more serious risk than your clients are in order to get a benefit. Availability of a treatment. That's another aspect of cost, of risk-benefit consideration. For example, if a new device has a very small significant benefit and there's a significant uncertainty about that benefit, we may still approve the product if there's no available alternative treatments and the probable benefits outweigh the probable risk. I mean, this is a perfect example of using SMR training on people who don't respond to medication, who have seizure disorders. I have trained a lot of people like that. And they call me up later and say, I haven't had a seizure in a year, 2 years. I had one client come in, hadn't had a seizure in 14 years since I last trained her, and she could not take medication. And Barry Sturman, in 2006 article, documents this in research, good designs. So this should be available. And the risk is minimal and the benefit is tremendous. Risk mitigation. The most common form of risk mitigation is to include appropriate information within labeling, warnings, precautions, or to restrict the indication to a more limited use. So I advise all of you, if you don't have it, to say what the possible risks and benefits are. And for most people, it's some insomnia, some agitation, some anxiety, and side effects from relaxation. And you can even go through what are the side effects of relaxation. It's not a bad idea to tell this to your clients and discuss it. Neurofeedback versus medications. A device may address unmet medical needs by providing a clinical meaningful advantage over existing technologies, providing a greater clinical meaningful benefit than existing therapy, posing less risk than existing therapy, or providing a treatment or means of diagnosis where no alternative is available. It is not unusual for novel devices like neurofeedback that address an unmet medical need to have relatively small probable benefits, and the FDA may determine the novel device to be reasonably safe and effective, even though the applicant demonstrates a relatively small probable benefit. So even if we're getting a small probable benefit from neurofeedback, they go from a seizure twice a month to once every 6 months or one every 9 months. And I would consider that more than small, but some people might minimize it. This covers it beautifully. So just to give you a sense of where neurofeedback might fall into these categories if you were ever legally challenged, you can see how safe you are and how much buffer there is here. And it helps get rid of, excess concern. You shouldn't be concerned, but it gives you a perspective. Risks of encountering a hypersensitive client. And they represent a case, and they say in this case it is known from the literature that the implementation of this device is not routine, and there's a 1% chance of death from surgery. So they're looking at a device and they're willing to accept a 1% chance of death. That's their level of tolerance. How many of your neurofeedback clients are willing to accept a 1% chance of death from neurofeedback? I don't think any of them want any. But some of them still might if they're miserable enough. But the odds of death from neurofeedback are so far gone. I mean, that's not even remotely probable. And that's the amount of risk that's involved here. Okay, so let's wrap this up. Let's talk about really where a lot of these effects are coming from. Autogenic training, biofeedback relaxation, deep breathing or breathing exercises, guided imagery, progressive relaxation, and self-hypnosis are all recognized as side effects of relaxation. And I've got the website, the government website. It's right down there at the bottom. This is going to be posted on the YouTube channel. You can go look at it. Go to that site. the government has this listed. They're completely aware of this. Relaxation techniques are generally considered safe for healthy people. However, occasionally people report unpleasant experiences such as increased anxiety, intrusive thoughts, or fears of losing control. This is straight off the government site. There have been rare reports that certain relaxation techniques might cause or worsen symptoms in people with epilepsy or certain psychiatric conditions, with a history of abuse or trauma. Notice that's in there. People with heart disease should talk to the healthcare provider before doing progressive muscle relaxation. I got a heart condition and I need to talk to my provider before I relax? Yes. So, okay, in this whole smorgasbord of government agencies and oversight, they recognize that there are side effects to relaxation. And just in case that's not enough, there was a great piece of research, and there's been several of these done by Banquet and others, but this one was a little more recent in the International Journal of Psychotherapy, which is a nice respected journal, in transcendental meditation. Just as a relaxation technique, it's a little more advanced than relaxation, but basically they're talking about psychological and physiological changes and negative side effects encountered by 62.9% of meditators studied. Even meditation, mindfulness, which they teach everywhere, you can get as much as 60% of side effects, and they call it side effects, and there's a good reason. While the authors did not restrict their study to TM, so they looked at others, side effects were reported similar to those found in a German study of transcendental meditations. Relaxation-induced anxiety, panic, paradoxical increases in tension, less motivation in life, boredom, pain, impaired reality testing, dissociation, confusion and disorientation, feelings of being spaced out, depressed, increased negativity, being more judgmental, feeling addicted, uncomfortable kinesthetic sensations, these weird things I'm having, mild dissociation, feelings of guilt, psychosis-like symptoms from relaxation and meditations, grandiosity, elation, destructive behavior, suicidal feelings. You did neurofeedback on me and I had suicidal feelings. Well, what did you have before? Let's look at your history. Defenselessness, fear, anger, apprehension, and despair. Okay, mindfulness can produce this. Relaxation can produce this. So it shows you where this stuff is coming from. So the conclusion, it's not the training, it's the relaxation response of hypersensitive individuals. The solution is not to panic, not to avoid, but better risk management, better neurofeedback technique. And so hopefully you got some ideas about what that might look like based on this presentation. And hopefully you will look at this again, think about it, and it will help you filter out that rare client that does occasionally come in and give you a basis for how to deal with them. Okay, with that, I'm going to unmute everybody. We've got a couple minutes here, and we can continue to talk about this at night next week. Right? People want. All right. All right, I'm opening it up. If anybody has anything they want to say, questions?
Richard, Martin, I just want to throw in a thought which is very supportive to you, to what you just have thought. Biologically, neurofeedback cannot cause something which isn't already there. What happens if somebody has an abreaction, in particularly what is called psychological abreaction, PTSD, trauma, and so on? What happens is something which is there when you start to relax comes to the noticeable perceived surface, but it isn't created. Because the moment you relax the body, the brain has capacity to start dealing with mess. And that's what it does. And the result of it will be that the person feels worse. Not because the problem has been created, but because now the person is able to feel the actual problem and starts dealing with it.
I appreciate
that is what an abreaction is.
Yep, I appreciate that. That's another way of saying it, and as many ways as we can say it. the better, because many people have different ways of hearing it. Thank you, Martin.
Well, this is also an explanation why the same thing can happen when you do meditation or mindfulness. You do exactly the same.
Mm-hmm.
So it becomes, it allows you to actually become aware of what is your problem if you do it.
It's a heightened state of receptivity.
But it doesn't create it.
Yep.
It's there.
Mm-hmm. Okay, anybody else have a comment?
Richard, it's John. FDA recognizes neurofeedback as useful for what? Treatment of relaxation purposes?
It's primarily relaxation. Mm-hmm. That's what it's seen as I recall. It's a Class 2 device registered for relaxation, can be used for relaxation purposes.
Hello, Richard. Kathleen.
Yes. Hey, Kathleen.
Hi. Gosh, I love this talk. I wish I had heard this talk about 3 years ago, too. I don't know what other people's experiences are. I have certainly had more than my share of these people, probably more than average because I'm a physician.
Right.
And I got to tell you, this is very good, very helpful to me, although I've certainly, through various ways, recognized this very quickly and worked. And some people leave right away, and some people I've worked it through with a lot of angst. But yes. I love the SMR and that testing and just going. I think that I'd never done that, and I'm just going to really, that's fantastic as like a test, because I agree with you. Getting people to deep breathe or doing a little HRV, boy, sometimes I trigger the whole ball of wax just with that. I mean, that's where I start with those people. And if I can't do that, I know, oh wow, we got a long haul.
Mm-hmm.
And some people do it if they're motivated enough, but it's going to be a long haul.
Thank you, Kathleen. That's great. It's exactly what I find too.
Yeah. Now, what's a little disturbing is the thought that a lot of these people might have Lyme. And that's a bit disturbing because, boy, that's a hard.
Okay, excuse me. I have to mute somebody.
There's some folks.
Victor is.
Oh.
Okay, there we go.
Richard, I have a quick one. You mentioned 4 things. I got 3 of the 4. You said that typically can be side effects of neurofeedback that I don't necessarily tell people. Insomnia, anxiety, the relaxation component of it, and there was something else.
Agitation.
Agitation, okay, yeah. I remind people of that. I mean, I tell them that, especially when you're training in the temporal region, I let them know, based on my own personal experience when I was in training, that it can cause you to be a bit irritable, within an hour or 2 after a session, and that could last, 30 minutes to an hour or so. But if you're irritable for more than that, it's not the neurofeedback. There's something else that maybe opened up inside of you that's an agitation issue. But okay.
Well, I think what we can do is we can provide a list of symptoms of relaxation along this line and you can say to your client, neurofeedback relaxes you, calms your nervous system down, and these are the known, the government, the FDA knows, these are the symptoms of relaxation. You may experience these if you ever relax, and if you do in our office, it's potentially there. And if you are showing them the risk and they know the potential benefit, then you've done your due diligence as far as the FDA is concerned.
Right, yeah. I was looking at that list and thinking, I wonder whether in the clinic I work at that the people who do biofeedback, and I really guess they do not, even make mention of any of this to the people they work with.
Yeah, we need to do it more. This last one from North Carolina was so provocative. I thought, we really need to just get the whole community going on this. So I'm presenting this at as many places as I can, and I'd like to put together a standardized risk-benefit statement and work with people on the Lunch and Learn here so that we can put together something really nice, a presentation, maybe even for the clients the first time in general.
Mm-hmm. Like a nice list of what would they call informed consent with all that.
Well, we're going to put up a PowerPoint and run them through it, just a short one, and then have them sign off, say, I saw the PowerPoint saying this, and we'll list underneath what the PowerPoint covered. And they sign off, it's there, it's done, okay?
Yeah, makes sense. Makes sense.
Hey, Richard, I know this is on you.
Really hello?
Yeah? Is that Dick?
Oh, it was. I was going to say two things that would be helpful. One is if there is a compilation of those 280 efficacy studies, I probably have 25, but if you've got 280, boy, I think that would be a good resource for all of us. The other, in terms of developing documentation, is that relaxation-induced anxiety is a search term that will produce a zillion articles from even the 80s on.
Thanks, Dick. That's a great resource. In fact, if you would post that, that would be terrific. Just that, what you just said would be terrific.
Sure. Hey, Richard, would you consider getting Sean to work on an index from the Q that would combine these things, you know, the different scores and algorithm?
I think it's too early for that. We need a larger population, but if people start sending us the Qs of people who are hypersensitive as a group, and there's quite a few of us, we might be able to come up with a real profile that's more obvious. At this point, I don't think it's, you know, the Qs are still different enough that I can't see. And we have to really look at the multivariates a lot more depth, you know, to see if there is such a, it's like looking at head trauma. There's so many different profiles. You can't really come up with a good discriminant for it.
You know, I think the key thing, honestly, and what I'm taking away, is to be more alert at the get-go of somebody who can help with neurofeedback and other people who you should absolutely just probably back off from.
Exactly, Kathleen. I think was my intention here.
Yeah, and that's a clinical thing. That doesn't come from a qEEG. That really comes, I mean, these people, believe me, within 1 or 2 sessions, you know when you're with these people. It doesn't take much. And I just don't think you need even you don't need a qEEG. You know, you just interact with them maybe twice, maybe 3 times tops, and you know. You know.
Yep. A lot of times
I agree, Kathleen. I agree. I've actually thought about whether it would make sense for me just to require everybody, at least after a Q, that has the profile that indicates maybe a hair analysis is in order, is to have them do that even before I start them.
My thought was, though, you've just lost 3 sessions, especially if you don't charge them, right? So, I mean, Len Oaks has a sensitivity question here.
Oh, I would charge them. I wouldn't necessarily, I never do neurofeedback the first session. There's an evaluation, you know, and I'm telling you, these people pop out pretty quickly.
Yep.
Or even like Richard said.
I agree.
If you put an electrode on their head for 2 minutes, which, you know, you can charge for an evaluation, and just put the sensor on their head, and you're going to know. The minute they feel a shift, they're going to say, ooh, ooh, or whatever they're going to say. It's quick.
Yep. Indeed it is. Okay, well, we're at the top of the hour. We can continue talking about this on Neuro at Night and in other days. We can even set up another day. Rob can put it on the roster, and we can talk about it. This is recorded, so I'll post this on the YouTube channel, and you can all look at it again if you want. We can talk about it more later. I know we all have limited time and clients waiting for us. So thank you all for your input and any future input on this, and we'll continue to develop this concept for everyone. Have a great weekend.
Okay. Thanks.